Hello, my name is Eunice Huang, and I'm the chair of the APSA Education Committee. It is my pleasure to welcome you to the first of a series of APSA created by the Education Research Subcommittee of the APSA Education Committee on the fundamentals of surgical education research. Today, we hope to share with you some basic principles, framework, and design associated with surgical education research. We hope that you will find this useful as you engage in scholarship in the field of surgical education. I am joined today by several very experienced surgical educators and surgical education researchers. They are our panel for today, for our discussion today. I will introduce all three of them. Our first is Dr. Samantha Ollie, who is going to be starting as at Hasbro Children's Hospital very soon. And she is also the inaugural chair of our Education Research Subcommittee. Next is Ben Zendejas. He is he's at Boston Children's Hospital. Many of you know him, and he is the vice chair of our subcommittee. And lastly, we have Mina Wick, who is at UC Davis Children's Hospital. So we're very excited to be here today to chat with you. We're going to go ahead and get started. We have no disclosures, and I'm going to go ahead and hand the podium to Dr. Wick to start our discussion.
Thank you so much, Dr. Huang. This is a brief outline of what we're going to be talking about today. It's a lot to take in, and we're going to try and give everyone sort of the 10,000-foot view of surgical education research. There's a lot of nitty-gritty in here, and we encourage you guys, if you have any questions, to reach out to any one of us or anyone else on this subcommittee. But we're going to start with talking about why bother with education scholarship in the first place. We wanted to start by talking about this because the whole idea of surgical education research and scholarship may be a little bit foreign. And scholarship and education, I mean, we do scholarship and we do education all the time for our trainees, for one another, for our patients. So what does it mean to do scholarship in surgical education? Well, it's really the same as scholarship or research in any other field. It's about creating a tangible product that presents new knowledge and is peer-reviewed and then disseminated. So the most obvious example of this is something like a manuscript that is a tangible product with some new knowledge in it that is peer-reviewed and then spread out. On the other hand, something like grand rounds is not peer-reviewed, so it would not qualify as something like scholarship. The purpose of it is to build on what's been done before. To have a question, kind of find the gaps in what's already been done on it, and then figure out how you can improve on the work of others. And by doing so, we drive our field forward and we improve ourselves as educators. And because as surgeons, being an educator is so fundamental to our identity, whether it's how we work with our colleagues or our patients or our trainees, it's really important that we think critically about how we're doing it and how we can be better at it. So let's start by talking about different types of scholarship. Now, this is not unique to surgical education research, but it's helpful to think about as we sort of classify what kind of studies we're going to do. So the first is the scholarship of discovery. And these kinds of studies ask questions like, how does X work? Why does it work? When doesn't it work? And why not? So in education research, it might be something as fundamental as, how does simulation work? How does an OSCE work? When is it good to use a standardized patient and when not? The next type of scholarship is the scholarship of integration. These sorts of studies ask questions like, what do we already know about it? And then how can we synthesize that to gain a new insight? You might summarize that knowledge for a new interdisciplinary group or a non-specialist audience. Examples of this might be systematic reviews or meta-analysis. The last type is the scholarship of application. So how can I apply what we know to solve this new important problem? And how can I apply what we know in a new way? So you might be asking something like, how can we take something we already know, like simulation, and apply it to something new, like non-technical skills? Another way to think about different types of scholarship is the purpose of it. There are three main purposes we think about: description, justification, and clarification. And typically, as the field moves forward, you move from more descriptive studies to more clarifying studies. And I'll explain what I mean by each of those. Scholarship that is done for the purpose of description really just looks at what I did. So you might describe a new simulation program. When there's new technologies coming out, this is a lot of what we see, but it doesn't really help drive a field forward. And so most times, this is not what we're looking for. And a caveat to that would be, say, in the recent pandemic, when people were doing a lot of like new telehealth. And then it was exciting to see what sort of new things people were doing to try and bridge those clinical and educational challenges. The next type of purpose is justification. And in this, we ask, did it work? Is what I did better than what was before? An example of this might be comparing simulation to no intervention, or simulation to some other standard teaching, like a lecture. The problem with these types of studies is that you have to be really careful about what you're comparing. Simulation to no intervention, well, generally simulation is always going to show an improvement because you did something, you provided some sort of teaching. So when doing these sorts of studies, you really have to be careful about comparing apples to apples so that you can gain some insight about what worked. The last purpose of scholarship is clarification. And this asks, why did it work? How does it work? When does it work? And so an example of this might be doing an intervention where you look at simulation versus a slight modification of that simulation. So let's say you wanted to look at the effect of coaching. You could do simulation with coaching versus simulation with video coaching. And that one small little tweak can really help you understand better the impact of video technology and when it works and when it doesn't. Now that we've talked about sort of the why and what of education scholarship, let's talk about some tools that are kind of unique to education scholarship. And the first is conceptual frameworks. Conceptual frameworks are a way of thinking about a problem or a study, or ways of representing how complex things work the way they do. In other words, it's a way for us to have a unified way to study something as abstract as learning. We all know what it is, but to be able to study it, you have to have a common way to think about it and a common structure to approach it from. So there are some important elements to consider in a topic, and that's what a conceptual framework tries to organize. You can think about the contents or the what of that topic, or the methods or the how of that topic, and then how to interpret those results. Conceptual frameworks can include models, theories, or best practice guidelines. Models sort of are just the organizational structure. Theories are a little bit more powerful because they start to address the why the model works. And it starts to incorporate some predictive aspects to it as well. Best practices, as we all know, are really about applying those models into everyday practice. So to help you understand a little bit more what I mean by a conceptual framework, here's a few examples. The CAN-MEDS and ACGME are two frameworks to use for how we evaluate trainees. CAN-MEDS talks about the different roles that a physician should be able to fill to be able to take care of their patients well. ACGME, on the other hand, looks at competencies that a physician should be able to display. So depending on which framework you use, you're going to evaluate your trainee in a different way. And similarly, depending on which framework you use, you're going to structure your research and perhaps the outcome or what you're using to assess differently. This is another conceptual framework that's a model for how people learn through experience. It's Kolb's experiential learning cycle, and it's pretty well known. And here you can look and see that he's organized the learning process into 4 concrete stages: concrete experience, reflective observation, abstract conceptualization, and active experimentation. And so depending on what you want to study in your learning, this can help you focus it. If you're doing an intervention like, say, a standardized patient encounter, is it affecting the experience they're having, or is it affecting how they reflect on it? What is more important in that learning? So once you have a conceptual framework, it can help you think about how the intervention or the assessment can be structured. So here's an example. Let's say you want to do a project looking at how you can teach suturing skills more effectively. If you use a behaviorist framework, then the assessments you're going to pick are going to focus more on practice and reinforcing what the students are learning. If you pick a constructivist framework, you may focus more on an intervention that uses mental strategies. If you use a social cognitive framework, then your interventions may focus more on modeling and group learning. So again, the conceptual framework you choose can affect the intervention or the assessment that you're going to use. Here's another example of how different theories of clinical reasoning and can influence teaching and assessment. So let's say you are using a clinical framework that thinks that good clinical reasoning requires a large and broad knowledge base. In that case, your teaching is going to focus on trying to increase that knowledge base by using things like lectures and readings. But if instead you think that good clinical reasoning relies more on a really good organization of that knowledge, then your teaching is going to focus more on things that organize that knowledge, like case-based learning and concept mapping. If instead you think that good clinical reasoning depends on cognitive processes and being able to coordinate and actually use that knowledge, then again, you're going to turn to things where they have to actually apply that knowledge, like standardized patients or case discussions. And so this is another example where, depending on the framework that you choose, it may affect what intervention you want to try and design and study. An important thing to realize about conceptual frameworks is that they focus on a subset of important aspects, but they may ignore others. And there are a lot of conceptual frameworks for any given topic, so it's really important to choose wisely. So once you figure out what problem it is you want to study, you can find conceptual frameworks by either searching the literature for similar initiatives or talk to other people who have done research in that area or who have used conceptual frameworks that you think are interesting. You can select different ones for contents and for processes, and then use those frameworks to analyze the problem and guide your choices. Here's an example of how you can use multiple frameworks, both to guide the content and your methodology. So in this study, they wanted to look at why learners were making limited gains from simulation-based surgical skills training and why they were having trouble transferring those simulation skills to the operating room. For the content, they used the FLS skills as their framework, and they focus on one skill, just laparoscopic suturing. And then they use, for the process, the conceptual framework of mastery learning and multiple resource theory. And they said that to be autonomous and to really attain mastery, you have to be able to do this skill while being distracted. And so their intervention was to have the learners try to do these skills in the surgical sim lab to the point where they were being distracted and still being able to do it. So you can use multiple frameworks for both content and for process to design your intervention. The next tool that I wanted to talk about that may be less familiar to some people is qualitative research. because that tends to be a fairly heavy hitter in surgical education research. Unlike the quantitative research that we're more familiar with, qualitative research is really about asking how and why. And so the ultimate goal is to formulate some new hypothesis or theory for why some observations were noticed. Data collection is through observation and interpretation rather than measuring and testing things. And the resultant data is often in words rather than in numbers and graphs and tables. That data is then generalized to come up with a hypothesis or a theory. And so the focus of qualitative research is often on subjective answers, and it's more about the context and the complexity of the answers. The division between quantitative and qualitative is not necessarily very clear and can be sometimes fairly contentious. The tools that people have for doing qualitative research can vary between semi-structured interviews, focus groups, observational studies, free text questions, content analysis, and archival research. These different methods vary in the primary data source and in how guided or open-ended the questions may be. But they are similar in that the resultant data is then coded, which means it's sort of chunked into these thematic units that are easier to analyze. There's no conversion to numbers, but it's really about more of that thematic analysis. So if you're interested in doing any sort of qualitative research, we'd highly recommend that you include somebody in your research team who's done it before and who's good at it. Or turn to somebody from, say, this APSA research group, and we'd be happy to help you. Now I'm going to turn it over to Dr. Ali for the next portion.
Okay, so we're going to start now by moving into talking a little bit more about the development of a research question. And developing a good research question is important and can also be really challenging. The question itself will not only guide your research project, but it will help keep you focused. And we want to be thoughtful about what specifically the intervention is, and then also what specifically the outcome we're measuring is. Because it will help us describe it'll help us determine what the outcome we're measuring is, and it will help us describe what population we're studying. So let's move on and start by discussing the intervention specifically. The key component of our intervention is that it's the independent variable. We want to separate the intervention from the outcome itself. In other forms of research, it's often much more intuitive, but in education research, it can be a little bit less straightforward. We don't want to confuse our intervention, the training, the teaching, the assessment, the what we're doing or how we're doing it, what we're manipulating, with the assessment or measurement of our outcome. So, for example, if we're doing a study with the question of, does amount of stimulation practice for a laparoscopic appendectomy affect a PGY-2's confidence level in performing a laparoscopic appendectomy? The intervention might be hours of practice, with one group having 1 hour of practice and one group having 3 hours of practice. But the outcome itself would be self-reported confidence level of the resident regarding performing the appendectomy at the end of the session. While discussing the intervention, it's a good time to start talking about what instructional design is and what it means. It's, again, something that's talked about much more amongst medical education research than possibly other types of research. It's a well-researched sub-area of how operationally an intervention happens. It's a guiding principle that helps make sure we're delivering content in a way that ensures objectives are clear, ensures the experience or the study design aligns with those objectives. It helps us make sure that our study is standardized across all participants, and it helps us align our assessment with what is being measured. There's a large body of research, again, about how we can use instructional design really as our intervention or our methodology, but we want to be careful of confounding variables or adding too many instructional design components into our research process. This is a table that just talks about the instructional design characteristics, or gives some examples of what instructional design characteristics could be helpful in medical education research. We can vary the clinical context. We can change the cognitive interactivity amongst our participants. We can incorporate different curricular components. We can spread the practice or the intervention over different time periods for different groups. We can change how we give feedback to our different study groups. We can change the way we allow our participants to practice something, either in a group or as an individual. We can change how much of a clearly defined standard our participants must have before we let them move on to a next level. We can change the number and type of learning strategies that we use. We can make our tasks more difficult, and we can change how much we let them practice. These are just some examples of what we can change as a single instructional design characteristic in our methodology that would really change our independent variable between groups and allow us to measure a difference between outcomes. So now let's move on to talking about the outcomes a little bit more. This is our dependent variable, what we're measuring, the expected or unexpected effect. In medical education, you often hear study designers talk about knowledge, skills, and attitudes or behaviors as the outcome. It's very important to define our outcomes operationally. People get into trouble when the research question proposes an outcome that is sort of abstract. We want the dependent variable to be precise, we want it to be specific, and we want to make it measurable. The type of dependent variable determines the data collection we use and the analysis that we use. When we try to measure the relationship between our intervention and our outcome, we want to have a sense of really what we're looking for. A difference, maybe, is something better or something worse. Did we find an association, which is maybe more of a trend, and something increase or decrease? And the purpose of thinking about this during the designing of our research question really has more than one purpose. When we design our research question, we want it to help us help guide us determine the study sample, like the population and the size, what data needs to be collected, and what statistical method should be used for analysis. When choosing our population, it innately determines the generalizability of our findings. So our sample must be representative of the target population for the study to be generalizable. So that's a little bit why and how developing the research question impacts the study as a whole. The type of study design we use is also really important. It's important as it will help us determine the strength of our own conclusion. As we know, causation is often easier to argue with experimental studies. Most of you are familiar with these types of studies and have seen or used or read papers with them before. We have observational studies, which will include case controls, surveys, interviews, cohort studies. They're cheap, they're fast, but we can't always control the data quality. The gold standard is often an experimental design where we randomize subjects or groups to participate in the interventions. We try to counterbalance that. It has the fewest biases, but it can be expensive, it can be time-consuming, and there are sometimes ethical issues with the group distribution or the creation of the study. We can do quasi-experimental studies where we do have a random selection of subjects, but they're not assigned randomly to groups. And then we're all familiar with meta-analyses. Something that's a little bit more unique in medical education research is an instrument validation study, where the purpose of the study is to see if a new tool or measurement strategy itself is working. Taking all of these considerations into account, we want to pick a study design based on what conclusion we want to draw, what's actually feasible, and what will minimize bias and confounding. And our research question and what we're looking for as an outcome will really help us guide the study design type that we choose. Okay, so now that I've spoken a little bit about the research question and studying the design, I'm going to turn it over to Dr. Zendejas, who's going to talk more about the outcome itself and measuring the outcome assessment.
Okay, thanks, Sam. So assessment and by consequence, the term validity or validation may often seem a sort of bit of a scary topic and something that has a bad reputation to some extent and is thought as only statisticians, psychometricians are knowledgeable of this, but it's actually not that difficult. I'm going to try to boil it down so that you can become an expert too in assessment and try to really think about how are you going to measure or assess your outcome so that the decisions or interpretations that you make out of that assessment can actually mean something. And so the key thoughts about this definition is that it really is a process. It's not a single static situation, and it evolves. You're not going to get all of the assessment information or validation information with one study, and maybe multiple studies, right? And you really want to have this idea that you're going to be gathering evidence, the vast majority of the times from multiple sources. I'll talk about what these sources are in a minute. But you want to create a validity argument. You're going to pretty much describe this argument, the pros and cons of the decisions that you've made in order to support the interpretation of your assessment. The particular situation and population, because it may change for a different situation and different population of a learner. But the key point here is that you're trying to support the interpretation of your assessment. You're not trying to support the simulator as a device. You're not trying to support the instrument or tool on its own. It's actually what comes out of that assessment that you're trying to create an assessment or validation argument for. So a few starting points for the misinterpretations that we often see. As I pointed out earlier, it's fairly common to see this misinterpretation, which the focus of the validation argument becomes the simulator or the educational intervention, but it's not that. You have to sort of reshape or reframe the mindset that it's really that assessment and the interpretations that come out of that assessment that is what we need to think about. Right, the most probably common misinterpretation is this: that the stating that something is already valid, and that we're using it because it's valid, and that I think we all are fall into that fault because we try to justify that we're using something that was already validated, quote unquote, and that's not the way to say things or to use it. Yes, using something that has some prior validity evidence adds to your validation argument, but that's just only one component, because you need to make sure that that instrument or tool or assessment applies to your population of learners, to your circumstance, and you still need to make a validity argument with all the other elements that we're going to talk about to see if the inferences or judgment calls or decisions that you're making based on that assessment are appropriate or not for your setting. So there's different frameworks on how to evaluate assessment, and the most contemporary and accepted framework by several organizations and folks who delve deep into this is that proposed by Messick. And in short, it has 5 elements, and we're going to dive deep into them: content, response process, internal structure, relationships with other variables, and consequences. Okay, let's see what they look like. So content is very straightforward. It's what is in your assessment. What's the content, right? What are the scenarios? What do the questions look like? What are the type of responses? What are the instructions? How did you come up with it, right? Where did you get it from? Was it based on a prior instrument? Was it expert review? Was it Delphi consensus, literature review based on a clinical guideline? et cetera, et cetera. Like what went into the development of that assessment instrument or questionnaire, or whatever it was that you're using to measure something. Like, where'd you get it from? Now, response process is how either the rater or the examinee behaves based on that assessment, meaning what are the responses that come out of this assessment, right? Are they well aligned with what you're trying to measure? And here goes into a lot of rater training. Are you ensuring that your raters are measuring the same thing? Have you done rater training? How do you manage rater disagreement, right? Is there a process for that disagreement, and how is it managed? Or is there a way that you're having a quality control for all your video recordings? If your assessment is based on video recordings, do you have a way to store it, to organize it, to edit it? What's your quality control of your assessment? In terms of, do the raters have to do any sort of judgment call or actions when they're doing this assessment? How is their behavior going to impact the test or the assessment? This is what response process means. Now, internal structure has to do with how each individual assessment item behaves with each other, right? So here's the more common or perceived measures of reliability, whether it's inter-rater, all sorts of variations of reliability, but essentially it's trying to see if I measure this thing again and again and again over different stations, different items, different raters, am I going to get the same thing? How reproducible is this, right? There's some more advanced ways to look at internal structure to try to figure out, is this question or assessment item measuring the same thing as this other item, and hence is it about the same, and can we simplify things, right? So you can kind of try to do item analysis and factor analysis to try to see what is the interrelationship between the items, and can you simplify, or are you heavily weighted to one side or the other? So there's ways to look at how these items behave with each other. Now, this is probably the more common source of validity evidence that we often see quoted or referred to. This is the relationships to other variables, mostly because it's probably the more intuitive one, right? You're trying to determine if the observed measure or assessment has any relationship, either known or unknown, with that theoretical construct, right? And short answer is like learner characteristics. Like, are scores on this or that better by PGY level as you would expect? Maybe not. Maybe there are. And they often talk about concurrent, whether it's at the same time. It can be something completely different, like a knowledge test. Is it concurrent or concordant with some skill assessment? Or is it delayed or predictive, meaning does it transfer to patient care, or is there some sort of retention testing that you're trying to do for a delayed knowledge test? So these are measures that are trying to establish that relationship between something that you would expect to be theoretically well aligned, or even not aligned. If you know that something shouldn't be aligned and they're not aligned, then that adds to your validation argument. Ultimately, I think one of the rarer forms of validity evidence, but which is unfortunate because probably one of the more important elements to discuss, is, okay, so what? Like, what do you do with your inference, or with your judgment, or with your decision of what you actually just measured? Like, what's the impact, either harmful or beneficial, of that assessment itself, right? So did you create a pass-fail score, and how did you create that score? There's certain standards or ways to establish that threshold, and you need to describe how you went about doing that. And what do you do with that score? Do you remediate? And if you remediate, does it get better? Or what are you doing with that assessment information? That's the consequence component, which is very important. So when is all of this needed? Like, it seems fairly complicated and so much work. The truth of the matter, it's needed every time you use an assessment instrument to measure something. And it can be as simple as just one paragraph in your manuscript to saying, like, where'd you get this tool from? How are you using it? What are the things that you're worried about the validation argument, because it all doesn't have to be positive about it. You can also critique it and highlight it as some of your limitations, but you have to sort of talk about it. And the reason why it's needed is because you're trying to judge whether the results of your study or the assessment in particular are they something you can count on? Does the evidence support its use, right? And then you're probably asking, well, how much of all that evidence do I need? It really depends on the stakes, right? So if this is going to be a very important exam, then you need a lot of evidence. If it's a new assessment tool, you're probably okay with starting with some evidence and gradually building up to it. But if you're making high stakes assessments, this is where you really need to have a lot of a validation or very robust validation argument. So a couple nice ways to think about the arguments themselves, right? Think about an attorney that's arguing a case before a jury, that they're really strategically seeking, organizing, and interpreting the evidence to present an honest and complete argument, right? However, it's the jury of users that passes that judgment. So it really ultimately isn't even up to you. That's the hardest part about this, right? You may think that your assessment and your interpretation of what you did is valid, but it really is on the end user of what you are trying to do, to kind of judge for themselves, is this actually an accurate interpretation of the data they're presenting, right? So you really have to create the strongest possible argument in order for that to be something that's acceptable. Again, as I said earlier, it's very unlikely and almost impossible that a single study will gather enough validity evidence to support a specific decision, right? You need to plan out different studies, particularly if you're starting with a new assessment, right? Maybe if you're using something that's already been used, here's where each study or your own study can incrementally add to the body of evidence that's already been published. And so you just need to say, where does your study fall into that argument, and what are you adding to in order to make that argument stronger for future uses of that instrument in different contexts. Okay. So there may be some difficulty to think about, well, how do I put all that into practice? How do I really come up and collect all these sources of evidence? There's a different framework that uses a lot of the Messick sort of approach to things, but puts it in a more practical approach. And this is Kane, K-A-N-E. And there's this really nice descriptive paper from Dr. David Cook, who's an expert in this, that talks about this practical approach to validation. I'm not going to go into a lot of deep sort of time into it, but if you're interested, you can we can talk about this more later. But it's essentially trying to get to the inferences and the judgments that you're making out of those inferences in a very sort of stepwise approach. So I'm going to finish up this section on assessment by just kind of reflecting on the common mistakes to avoid, right? Please don't reinvent the wheel trying to make a new assessment every time. There are hundreds of assessment frameworks, instruments, and ways to measure things that already have some validity evidence to it. They may not be validated entirely because that just doesn't exist. As I said, it's a process, and there's always going to be more validity evidence to accumulate. And also keep in mind the validation framework that we talked about. The most common one is Messick, and I think you can kind of fall on that one, but there's a few others that are worth considering. Don't rely only on expert-novice comparisons as your main point in your argument, because those are very obvious, right? I think most things are able to discriminate between an expert and a novice, right? You really want them to be able to have more granularity and distinguish between the intermediate groups. Don't create your study or your assessment on what's easily accessible, but really think about what is more important. What is the important component of that assessment argument, which is usually consequences. So the other thing is, same thing, don't focus on the instrument, focus more on what you're going to do with that score or that interpretation of that score. A few other things is don't ignore some of these best practices that we already talked about. Really give as much details as possible as the instrument. Reference it, sometimes even like show it and say how you came about it, what process you used. So the more detail about how your instrument was developed, what are the steps that you did to ensure that when you were applying the assessment, it was accurate, and then what are you making out of each result of your inferences? I think that's the more important thing. Same thing, don't focus on the simulator for assessment, and don't label the instrument as valid. Okay, gather evidence, allow folks to make their own judgment.
So now that we have talked through the whole process, we're going to go through a practical example of how we can turn a surgical education research idea into a project. So the first thing we want to do, as we talked about, is define our question. So if we want to go into an example of that, I'm going to use a study looking at how does the quality of narrative feedback compare between end of operation evaluation forms and end of rotation evaluation forms. So there we're really defining our question. And then once our question is defined, we can go to the second step, which will be identifying our framework. So if we want to click through, identifying our framework for this specific question would start with a literature review, and it would reveal the following frameworks. That feedback improves performance, we know that, and then that's a good guiding principle for a research question like this. And we also know that supervisors find it hard to give timely, constructive feedback. So those are important concepts to think about as we create the study, looking at two different evaluation tools. The third step would be to identify the type of study that we would want to use for this particular research question. And a good way to do this could be a retrospective review of the evaluations. The next step would be to create the study design based on that. For this specific research question, one way to do it would be to use a rubric that would rate the quality of the end of operation and end of rotation narrative comments, and then compare those two using a chi-squared analysis. After we've created our research question and our study design, we would want to go ahead and choose our sample. So an example of a way to do that could be to choose categorical general surgery residents, clinical years 1 to 5 from 3 different institutions to try to make it more generalizable and make our sample population similar enough to our target population, which could be all general surgery residents in the country. We then have to carefully create our intervention. And in a retrospective review, we don't really have an intervention. So we want to be thoughtful about, again, what our research question is, what our independent variable is, and then what we're measuring. And here it's all retrospective, so there's nothing new that we're doing. And then comes the measurement of our outcome. So for this study, we would go ahead and compile the ratings of the narrative feedback from both the end of operation evaluation forms and the end of rotation evaluation forms. And we would progress to our analysis, which is the final step, which would be a chi-squared analysis to compare the ratings of the two different evaluation tools. So this is all an example of how we can go ahead and turn a research question, being thoughtful about how we're creating that question, into a project all the way through the analysis phase. We wanted to briefly touch on some common pitfalls. I know Ben already talked about some of the validation and assessment pitfalls. This academic medicine, they call it a book, but this is really a compilation of many different one-page studies that happened over the course of 6 years and is a really, really good resource for medical education research. So we'll start by talking about some of the common pitfalls of survey design and development in medical education research. When medical education research really started, a lot of the interventions or tools used to measure were surveys. That has changed a little bit now, but it's important if you do use a survey to be really thoughtful about how you're writing the questions. You want to avoid creating double barrel items. You want to avoid creating negatively worded items. You want to make sure you don't have too many or too few response anchors for the people filling out the survey to attach to, or what we call agreement anchors, making the participants want to agree with the wording or what you're saying. And then if you're using any sort of a visual survey, you have to be really thoughtful about how you're visually designing it to avoid participants picking an answer just based on how things are visually laid out. There is another paper within that book that discusses some of the common data analysis phase pitfalls. You want to be careful about how you're treating your design. If you do your analysis such that you're acting as you only have one independent variable, but you have two, your analysis will be wrong. You want to think about how you're treating your pre-test variables and your post-test variables. And you want to think about how you're treating your data, what type of spectrum it's on, if it's hierarchical, and how you're using your analysis with that. And then finally, if you do have an experimental study in medical education research, you want to use a lot of the same guiding principles and avoid a lot of the same pitfalls you would use in any sort of clinical or other experimental research. You want to make sure you're doing the proper hypothesis testing. You want to make sure what you're reporting in your paper means standard deviations all align with what you're asking and what your analysis shows. It's important to test for interaction between your variables to prevent confounding. And it's important to be thoughtful about how you're treating your data based on which scale it's on. So this really brings all of what we wanted to share with you guys to a close. We're each going to kind of go around and summarize some of our key points now to really hit home what we wanted to make sure we were expressing through our presentation.
So going all the way back to the beginning, surgical education research, like research in any other specialty or any other field that we may choose, is really important so that we can take a critical look at the education we're providing for our colleagues and for our trainees and for our patients, and so that we can make sure we're doing a good job, we're being effective with it, and so that we can push our field forward and push ourselves forward as teachers and as educators. It's really important that you understand how to use some of the tools that are unique to surgical education research, or to medical education research really, conceptual frameworks and qualitative research. And if you have any questions about how to utilize those, or just want a sounding board, besides going to the literature, using your colleagues in this APSA Surgical Education Research Subcommittee is a great way to move your project forward.
We also want to make sure we're hitting home that the development of the research question really in and of itself is important, and we need to be thoughtful about it because it guides the development of the whole study. We also want to be sure that we're really operationally defining our independent variable and that we don't confuse this with our measurement tool or our outcome. And lastly, instructional design can be a really helpful way to focus in on an intervention strategy.
Don't forget that the assessment is as important as the educational intervention. All education research that involves measuring or assessing something needs to have a validation argument in which the validity evidence comes from multiple sources. We talked about content, internal structure, response process, relations to other variables, and consequences. And we really need to judge those elements, not just in isolation, but as a whole, in order to support or refute the interpretation of the assessment for that particular learner population in that particular setting. Thank you.
Thank you all for tuning in to our inaugural medical education research episode. We do plan to follow this with a live webinar with audience participation and experts in the field that will help walk us through different examples of types of medical education research, and then some examples of how different research questions have been turned into projects. We plan for this just to be the beginning of a toolkit, and we hope that this can eventually progress to even having think tanks to help with development of medical education projects amongst anyone who's interested in our APSA community. Thank you, and we look forward to the next time we get to all talk together.